Welcome to this webinar on reinventing social prescribing services in times of crisis and recovery. So this is a webinar, as you probably already know, organized by the Broadway by Bow Center, but we've got some guest speakers to talk about other social prescribing services as well. And I'll introduce the speakers to you in a minute. So just as in terms of introduction, so for those who haven't seen me in a webinar before, I am Berenice. So I am the program manager for the Knowledge Share and Exchange program at the Broadway by Bow Center. So I organize this kind of webinar or workshops, and which would normally run in person, but obviously it's still not quite possible at the moment. But hopefully we've been learning from those times as well. And we'll continue doing some online things so more people can attend and yeah, kind of network and exchange ideas. So in terms of a little bit of housekeeping, so today, please feel free to just introduce yourselves in the chat box. We'll be here for an hour and a half together. So just say who you are and where you work, where you're based. So that would be nice just to get to know each other a little bit. We also have a Slido. I'll put the link in the chat box in a minute, just when I'm done talking. There's also a code that you can see on your screen normally, but there's a direct link as well that I'll just paste in the chat box in a second. You can ask your questions there, and there are also going to be some polls at different times during the webinar for you to kind of participate in the discussion as well. A recording will be available after this live session. So please do keep off camera if you do not wish to appear in it. Normally it should only show people who are actually speaking, but you never know. So if you really don't want to appear in this, then please do keep off camera during this session. In terms of what we'll talk about today, so obviously this is the introduction and welcome bit. We will then have presentations and Q&A from our 3 different social prescribing services to talk about the changes and the learnings during the acute and recovery phases of COVID. We'll then have some, then the rest of the session will be more of a discussion and some Q&A. We'll first focus on clients, working with clients and managing caseload. And then we'll kind of have a little bit of a send-off conversation about what we think social prescribing looks like in the future and what kind of lessons have been learned during the COVID times. And so that's what today will be. Today with us, we've got quite a few speakers, actually. I hope I haven't forgotten anyone. So from the Broadway by Bow team, we have Alex Drake, who is social prescribing link worker at the center. We have Emma Owena-Madison, who is Assistant Director of Population Health at Broadway by Bow Health. Jess Walker is a Community Driving Change Program Manager at Broadway by Bow Center. Then from the Hertfordshire team, sorry if I'm mispronouncing, it's really difficult for me as a French person. So we've got Tim Anpilogov, who is Head of Community Resilience at HCCGs, and NHAC Regional Associate Social Prescribing East of England. We've got Marianne Lindsay, who is County-wide Manager at Hertz Help Hospital and Community Navigation Service. And finally, from the North Islington service, we have Craig Seymour, who is the Clinical Director of Islington N1 Primary Care Network, and also Board Director at Islington GP Federation. So hopefully I haven't butchered anyone's job title or name. So before we get into the presentation, I actually have a colleague with me who I am going to enable to unmute now. So Freedom is actually Social Prescribing Training Manager at Broadway by Bow Center. We work very closely together, sorry. And Freedom, would you like to say a word about what we do at the center in terms of training for link workers? You've got a couple of minutes for that.
Yeah. Hi, everyone. My name is Freedom Duma. I am the training, I'm Social Prescribing Training and Development Manager at Broadway by Bow. So my role really covers across the UK. So I've been working with link workers and scheme managers across the UK. So just briefly, our training program is designed to support and train social prescribing link workers and other similar roles. And yeah, so over the last 7 years since we started delivering social prescribing training, so we've worked with GPs, different commissioners from across the country, voluntary sector leads, yeah, and yeah, so we've been able to reach over 600 link workers since we've started training, and we're predicting that over the next few years we are going to be reaching out to a lot more link workers, since of course you know, there's more link workers coming into the system, so which is really good, and yeah, so we're just looking forward to connecting with different commissioners from across the country, different link workers and scheme managers as well. Just to give you an idea of the areas where we've trained, you know, we've trained link workers in from Scotland. We've trained link workers in Northern Ireland, London, of course, and across England. We've also trained link workers in West Wales. Just to give an idea of some of the programs that we have, we've got a level 3 accredited certificate in social prescribing, and we also have a program which we called, it's a 5-session program which we called Social Prescribing the Essential. So this is a 5-session course which is absolutely brilliant for new link workers, and obviously in those who have been in social prescribing field for some time as well. We also have other specialist courses that we offer to link workers and other similar roles across the country. And yeah, so I'm sure Berenice will be sending more information for you guys, and we've just released a new brochure. If you haven't received one, we'll be able to send you more information. And yeah, so I'll be very keen to have a chat with you at some point if you wanna connect. So yeah, I'll be very interested in connecting with any one of you. Thank you, Berenice.
Thanks, Freedom. I've put a link to the website and also the Freedom's email address in the chat. So if you want to get in touch, please do feel free to do so. All right, so it's now time to get into the first part of our discussion about what's been happening in our different services. So Broadway by Bow, my Broadway by Bow colleagues will kind of tell you about what's been happening at the center first. So I think you guys should be able to unmute yourselves, and if not, do give me a shout.
Thanks, Berenice. So yeah, as you said, we're just going to run you through some of the ways that we adapted during the pandemic and some reflections. We've also got some additional speakers too. We've got Naseem, who's a rapid social prescriber, and Ricky, who's a community outreach worker on the program that I managed, Communities Driving Change. So prior to the pandemic, we were working a bit like 3 separate teams. We had the population health team, which is part of the health partnership, Bromley by Bow Health Partnership. And they focused on one-to-one support for patients who needed wider support, training and learning and for the practice, community development and group work, as well as a bit of strategy. So Communities Driving Change, the project I work on, is a health and wellbeing project that works to build community capacity through training and coaching, strengthening local connections and collaborations, and supporting residents to develop and run their own projects that benefit the wider community. And also the social prescribing service, I can see many of us here are involved in social prescribing as link workers or otherwise, so you're very familiar with what that means. So in February and March last year, the situation led us to adapt our services, to start working in new ways and to respond to the community's changing needs. the three teams that I just mentioned started to collaborate in a different way, much more closely, and we formed a new wider team called the Integrated Health and Wellbeing Team. So we're going to hear about some of the reflections of what it was like during the pandemic and to be part of this wider team. Over to you, Layla.
Can you hear me? There's always technical issues. Hi everyone. Yeah, thank you, Jess. My name's Layla, and I work for the Social Prescribing Service at the Centre. I'm going to just talk really quickly because I'm sure you want to hear about what our wonderful team have been doing. But basically, the pandemic gave us a bit of an opportunity at the Social Prescribing Service to kind of reinvent the way that we were working. What we did know during the pandemic is that it was really important for us to continue our kind of traditional longer term social prescribing to support to patients during the pandemic. But we also needed an element of being able to provide more rapid or urgent support to address more of the more sort of quicker sort of the needs that needs to be addressed quite quickly for patients. And another important thing that we wanted to do is that we wanted to start to engage with people in the community who we might not have traditionally engaged with. So those were the kind of three areas I think that we wanted to focus on. What we decided to do was create a rapid social prescribing service, so create another social prescribing pathway. We employed a rapid social prescribing link worker, and you'll hear from Naseem in a bit. And what that just meant is that we were able to kind of see patients sort of a quicker turnaround and address more of those urgent needs that they were dealing with, such as connecting them to food-related support, domestic violence service organisations, pharmacy or medication organisations, all the things that were related to kind of like the pandemic. What that allowed us to do was continue offering our sort of longer term social prescribing support over a longer period of time, where we were able to address more of the kind of emotional needs of individuals and build resilience and confidence. Another element to that, as Jess mentioned, was the community engagement element. And that was tapping into the fact that not everybody was going to go and see their GP if they needed support or help with their health and well-being. And what we needed to do was actually proactively engage with the community. And we did that by contacting people through running searches on EMIS and seeing whether people needed support. And what we found from that piece of work was that we were able to engage a whole entire group, a new set of people, which was really, really exciting. And we were able to do this because we were able to kind of integrate and pull all of our resources together across the Bromley by Bow Social Prescribing Service, our health partnership population health team, and also our community driving change team as well. And that's definitely something that I think we want to continue with post-pandemic. But what I'll do is I will let the wonderful team talk, but if anyone has any questions for us, yeah, just let me know. Thank you very much. I'll pass it on to, I think it's Alex.
Hello everyone, I'm Alex. I am part of the general social prescribing team at the Bromley by Bow Centre. So I'll just explain a little bit more about my journey. So I actually started in my social prescribing journey in a PCN separate to this, and I was a lone link worker, and then in August I joined the Bromley by Bow Centre. And I guess what I would say, what I've learned has been the most crucial element of keeping going has been finding a team around me. So very privileged here because we have regular team meetings with the general social prescribing team, the rapid response social prescribing team, and then the communities driving change team. So we get a regular check-in to see how things are. We get to share client cases that might be troubling us and would benefit from kind of other, I guess, viewpoints, because you kind of always approach it from one direction, I guess, and even having another SP or someone outside of SP, in fact, like community driving change, giving us their perspective has always been helpful. But we, as a team, kind of, I know that Naseem identified that actually we needed space as a team ourselves to just come together and talk about anything, whether it was a caseload or actually whether we just kind of wanted to rant about something, because I'm sure you all know that this is a very intense job. And as social prescribers, we all do this because we care, but we're not immune to loneliness or isolation or just feeling a bit on top of things. So having things pile on top of us. So having that space to just share our feelings, share our thoughts, check that we're doing the right thing has been invaluable. So we do that kind of on a weekly basis, once kind of on different days during the week, because we have some team members who are part-time. So we want to make sure that everyone can access that. And then we also have a daily social prescribing hour, which is led by Layla, our manager. So that's just if we're ever worried about a case during the day and it's getting on top of us, we can just talk to her about it. And I found all of those things very valuable. I acknowledge that we're in a very privileged position to do this. What I would suggest, because I've been in that position of not having anyone to talk to, being a lone social prescriber, is that I would reach out to whoever you can find, whether that's social prescribers in surrounding boroughs or areas you might want to speak to, ask how they're finding it, how they've managed to get their foot through the door, or reach out to your regional learning coordinator who can get you in touch with peer groups. So that's exactly what I did when I was on my own. I just sought out any kind of company I could, because I have always found in my previous roles that I benefit from being able to bounce ideas off of each other, and having that team there with all their different expertises and experiences has just been invaluable. So that's what I will say, and that's enough from me. So I will pass on to my wonderful colleague Naseem.
Hi there, my name's Naseem, and I'm part of the population health team, and I work as a rapid social prescriber. So since we've been working together as an integrated health and wellbeing team, it's made it easier for us all. As you heard from Alex, we have team meetups, and that's where we, one of the things we discuss is what's happening locally, what groups and services are around. And what we do is we utilize the different strengths and connections each team member brings to the table. And because we have that intimate relationship with the team, the journey for both the patients and for us, it feels more feels a more seamless, personalized approach. So for example, Ricky, who's part of the community drive change team, mentioned in a meeting that there was a local food store that had opened up, and it was a scheme aimed to help families shop groceries at a much reduced price. So I sent a few referrals to them, but after a few weeks, I didn't hear back from them. I emailed them, I called them, but had no luck. So I got in touch with Ricky, and Ricky immediately must have got in touch with them, because they called me on the same day and apologized. And, you know, without that, without that fantastic intervention, or without that, I think what I would have done is would have given up or tried somewhere else. And who knows, those families may still be struggling. And you know, this is a tiny snapshot of how different teams can work together as one. Pass it on to Ricky.
Thank you, Naseem. Hi, everybody. My name's Ricky. I am part of the Community Driving Change team. And I echo what Naseem and Alex have been saying about being part of this bigger team. Especially for myself, it's allowed me to reach out to residents, patients that I probably wouldn't have seen in like a GP surgery or a community centre. But also it's allowed people to be in communication with us that haven't got sort of time to be out and about because they've got family responsibilities. One of the key residents that I can give an example of was this this woman that I spoke to when I was doing the wellbeing calls. She was really interested in trying to do something for herself and her own sort of mental health during this period of time. So we had like different online sessions that were happening, for example, a photography course, which she came to, and she really benefited from that. it allowed her to focus on something else, something positive for her. And it also allowed her to access other forms of Zoom sessions that we're doing. So recently we've done a mental health workshop alongside being part of this bigger team, where she sort of attended, and she instantly after the session messaged saying, "Thank you so much. This meant a lot to her, and she feels stuff like this is really important for her to be coming on to." So yeah, no, we have definitely reached out to people that we couldn't in the past, and it's been great, but there's been sort of challenges in the way. Sometimes it's hard for people to come onto like a Zoom platform, but we've worked with that, and we've done other things to help people still access stuff on an online platform. And going forward as a team, we still continue to work together. As Alex and Nassim were saying, we have our weekly meets. We're going to plan some more sort of mental health workshops together, which residents and patients have requested. So yeah, the journey still continues. Back to Bernice, thank you.
That was great. Thank you very much for sharing your experience. I saw that there are quite a few questions, and I saw as well that Emma is on it to answer questions on in the chat. So that's good. And maybe we can come back to a few of those things later on. Maybe we have 1 minute to take one question. What a rapid social prescribing team look like post-ish pandemic? Does anyone want to answer to that?
I can jump in very briefly. So I suppose the need for very rapid and sort of crisis support might dwindle as the pandemic situation changes. But I think what we've realized is that there is a need for differentiated sorts of access to social prescribing. So some people need kind of quite a quick turnaround and practical support. And it can be, it's often about signposting, it's often about kind of untangling a situation that's happening right now. And what we found is, as Layla was saying, that often leaves room for the longer term, more emotional and sort of behavioural change support that general link workers are able to do. So it might, the nature of that added layer might change, but we do think that there is a need for differentiated sort of layers within the team to capture and respond to all of the needs that come through the scheme.
Thanks, Emma. I hope that answers the question. So next we have Marianne, who is going to tell us a little bit about the Hertfordshire service, and Tim will be joining her. I don't know if now or later on. Later on.
Yeah. Okay, so can you all see those slides?
Yes.
Okay, so thanks for having us. I just thought I'd just give you a bit of background into sort of the social prescribing service in Hertfordshire. So back in 2014, the Herts Valley CCG commissioned a social prescribing service, and it was a team of 7 community navigators. That's how it started off in Hertfordshire. It then grew in 2017 to an integrated team of people supporting those coming out of hospital, as well as supporting the community and the GP practices. So what we have now is we have an integrated team of community navigators and link workers working within the service. So we're a partnership of 7 voluntary organisations, all working in sort of a matrix management system. So I'm employed by, for example, for the British Red Cross, and my senior link workers are all employed by different organisations, but we manage the service internally between us. So that is what our service looks like at the minute. So you can see that the orange is our senior link workers, the light blue is all of our community navigators, and the dark blue is all of our link workers who work in an integrated locality team to support that locality. So I think the difficulty for us was, just as we recruited 26 link workers in January 2020, we were going through their inductions, and then COVID hit and we went into lockdown. So the good thing was that we'd already established referral pathways from the hospitals, from the GP practices. We had our referral forms on EMIS, on System 1, and we were able to quickly embed the link workers into the practices because they knew about our service. The other thing we have in Hertfordshire, which is really fantastic, is we've got an organisation called Hearts Help. And this is one number for the whole county where anybody can call in if they have a situation that they don't know what to do. And Hearts Help will refer directly into the service that's needed for that person, or they refer directly into the hospital and community navigation service. So that's a one-stop shop for all residents in Hertfordshire if they're not picked up by their GP or in the community. So I think, it's just really interesting what sort of Alex and Naseem and the team were saying about moving to remote working, because we were so used to having face-to-face meetings as a team. And so what we did as well was we moved from having monthly meetings to weekly catch-ups just to see how the teams are coping, personally, and their caseloads, etc. So the good thing is one system, one team, the referral routes were already established. And what we had to do was we just had to engage online. So everything moved online, making sure that the GPs were aware that the link workers were there and that the hospitals knew that we were still there to support them. So what we did see a lot of is more sort of immediate, urgent needs. So it was food shopping, prescriptions, that's what everybody needed. I think in April, we had 2,000 referrals into the service for support with food shopping and prescriptions. So the great thing is we work in partnership with Hills, which is the Meals on Wheels service in Hertfordshire. So we, quickly said to them, okay, we're able to support with this, but we need food boxes. And so we'd collect 100 food boxes a week from them. And they would, and then we would have them at different sites across the county for the teams to distribute those. And Hearts Full Stop as well provided the food boxes for our team, so we didn't have to worry too much about shopping. We managed to book people online shopping slots, which was really great. But what we were mindful of as well was we didn't want to lose that social prescribing element, because just because we'd gone into lockdown didn't mean those other needs that we were supporting people with before had just disappeared. So we moved a lot to telephone support. And what we realized really quickly was that we needed to call in other services like Mind to support people with their emotional well-being. So it was really the voluntary sector coming together to say, right, what are the crisis points within the first lockdown, and what are the organizations that are there that can support with that? So that worked really, really well for the teams. So we were able to use the NHS responders and the mutual aid groups to do those quick shopping prescription collections while we focused on sort of the social prescribing needs for the people that were coming to us with those issues. So what happened as well was we realized actually there's a lot of people that are not being reached, and how can we reach those people that are obviously now shielding, unable to go out. So we worked with the sort of CCGs, first of all, around data sharing. So they wanted to know what we would do with lists we received, where they will be stored, how long they would be stored for, etc. So what we did was we encouraged the GP practices to send us over their most vulnerable patient lists, or their carers lists. And what we could do was, because we work on one system, we could add that to our SharePoint and have a team of 73 staff calling thousands of patients just to find out how they are and if they need social prescribing support or immediate support. We also worked with the high intensity user service, so because they withdrew from the hospital. So we brought them into our service to assist with those calls, as well as the Mind link workers as well. So the team grew from 73 to about 90 to support making those calls. we then realized, okay, so what else can we do to support our communities? A lot of people were struggling with sort of tenancy issues in housing. So we worked with housing to contact their most vulnerable patients just to see how they are, what support is needed. And so we were able to contact about 1,000 people on those lists. We also assisted in helping to book in flu jabs, as well as booking in the sort of first in December, the first vaccinations. They needed help calling people to book in because that happened quite quickly. So what we're seeing now is sort of a lot more complex cases coming in. We've seen a drop off from the immediate shopping prescription collection needs. We're very mindful that we need to be aware of how our staff are feeling. We've all been in this pandemic together, so just because we're social prescribers doesn't mean that we're not going through our own issues in our personal lives. So it's just being mindful that it's not about numbers at this stage. It's actually about recovering for all of us and making sure that everybody is supported, whether they're staff or patients. The main issues we're seeing really around finance, debt and benefits, unemployment, mental health, carer support, bereavement support, depression, anxiety, and social isolation. So what we do in our service is we capture the issues that we support people with rather than just capturing a case. So we could have one case, but we're supporting somebody with 4 different issues. So we're able to get a true reflection of what's going on in each locality when we pull up that data. And then we're able to feed back to the commissioners to say, actually, we need more mental health services, or we need more prescriptions within the community. So that's where we're at the minute. And I will lead on to the last slide, which is from Tim.
Hi, thanks, Marianne. And I want to start by just taking my hat off to Marianne in particular, but all of the link workers and senior navigators in the system in Hertfordshire, because the flexibility that they've shown has been amazing, particularly during the first lockdown, when I think, Marianne, you were delivering food parcels yourself to obscure villages somewhere in the middle of Hertfordshire on a Sunday evening. And I think the voluntary sector as a whole has done an amazing job during the crisis, and we need to build on that going forwards. I've only got one slide, you'll be glad to hear. And also, I've got a picture of Captain Tom, because everybody loves Captain Tom, but I think it's quite an important example of what ordinary people-ish in the community can do. And I think it's also really important that we've used the resources that he raised in an integrated way with the other stuff that we're doing. I should say 4 days a week I'm a commissioner, but the other day a week I am a regional facilitator for NHS England for social prescribing in the East of England, and I see some East of England colleagues on the call, so do contact us if that would be helpful. I just want to make a couple of points, because I think you've seen that the infrastructure in Hertfordshire is actually quite sophisticated. And I think that that's important because, as Alex was saying, a lot of link workers are very isolated, and particularly during COVID, they've been incredibly isolated, some of them, where they're just one person employed by perhaps a PCN that doesn't fully understand social prescribing. And I think that's something that we knew from the beginning. We wanted to make sure people were in teams, properly supervised and well supported, and I think that's really important going forwards, because even if you're in a place where all the link workers are individually employed by separate PCNs, as Alex was saying, it's really important that that's networked together, and I think commissioners have a really important role in supporting that. My second bullet is about collaboration and the fact that under the DES, and I don't know how technical you want me to get, but basically PCNs need to show that they have a social prescribing plan locally, which is agreed with the local authority. And so what we're doing in Hertfordshire is actually providing them with a template to help them ask the right questions. And some of those questions are very much about what is a social prescriber for post-COVID, because we were all clear beforehand. You know, basically someone went to the GP didn't know what to do with them, referred them to the link worker. That was the model we started off with. As everyone said, that kind of stopped at the beginning of the first lockdown, and we had to reach out to people. And I don't think we want to stop reaching out to people. I don't think that's the future. So therefore, in terms of, as Mary Ann was saying, in terms of the numbers of referrals and stuff, that's not going to be the key thing going forward. The key thing is, what's the best thing to do for your population, and particularly that bit of the population whose health inequalities are the most challenging, and how do we support them going forwards? One of the great things about the system in Hertfordshire that Mary Ann's worked so hard on is the consistency of the data that we're able to pull together. It's taken a while, but they have a system called Clear2, and that means that we can easily assess the numbers of types of referrals. So obviously money is one of the big problems, loneliness is another, carers, and so on. But also the organisations people have been supported to access following the social prescribing. And that, I think, is going to be a really useful tool for us as part of the population health management agenda. And clearly, because we've got 73 workers in that system, that's an awful lot of data, which should really tell us some quite interesting things. As I mentioned, Captain Tom's money came just, we worked very closely with the County Council to make sure that we put the bid in as early as we could, and picked up on the burning needs that were really in everyone's face. So particularly the need to do much better with BAME communities, and we've recruited specific workers to help with the cultural competence of the whole social prescribing system. We've got digital inclusion work going on, and we've got laptops and tablets being donated, but also data, and working to make sure that people who really need that access for their well-being can have it socially prescribed to them. We're also developing in Central Watford a particular population health management pilot where the link worker and the BAME workers are actively engaged, because it's focused on people from minority ethnic communities who aren't managing their diabetes. And we think that's for a range of reasons, but we know we won't find out until we reach out to them and have those detailed conversations and see if we can come up with culturally appropriate ways of helping them to manage their diabetes. So a really interesting project, and one I think which shows or helps us to show the future of social prescribing. Lastly, because we're so short of time, I've just put the link there to a blog I did for NHS England on the future of social prescribing. It raises a bunch of questions about what we think we're trying to achieve going forwards. But I think I would want to come back to the central point that what we're trying to do is the most effective thing for the community where that PCN is to help them climb out of COVID, basically. And that will vary very much depending on your populations. Obviously, Tower Hamlets is rather different from rural East Hertfordshire, for example. But social isolation will take very different forms. But we need to be thinking about how we reach those people, especially if they're not going to be finding it as easy to come into primary care and therefore trigger the referral. And I think the balance between referrals and outreach, and the balance between all of that and community development work, needs to be thought through really quite carefully, because link workers have had a pretty hard year and a bit, and we certainly don't want to drive any more of them mad than we have to. So I think it's really important that they get the right support and focus over the coming years, and I think commissioners need to be involved in that discussion. And I'll leave you with the fact that, as I said, we've got a template now for a local plan. I'm very happy to share that with anybody who might want to have a look at it. It doesn't set anything in stone, but it suggests the sort of things that we would want primary care networks to be talking to their local authorities and their local voluntary sector about when planning how they do their social prescribing going forwards. And I'll leave it there. Thanks for having us. It's a great delight to be virtually at Bromley by Bow, the World Centre for Social Prescribing.
Yeah, thank you.
Thank you very much. We have 1 minute for a question about how are you coding and extracting your information?
So we have we use the SNOMED codes on EMIS, but what we do is our link workers use our Clear2 system as well, because the data is much richer there, and then we give the PCN a report every month.
Great, thank you. I hope that answers the question. And now we are going to move on. Thank you very much, both. That was great. And we are going to move on to our third service, which is represented by Craig. And we're going to spotlight now. Hi, Craig.
Hi, let me just try and bring this up to share with you. Okay, those should be on your screen now, is that right?
It is. Do you want to make it? Yes.
I'm going to make it bigger. There we go. Hello, everybody. Thanks for having me. What a privilege to be, as Tim just said, with the World Centre for Everything Social Prescribing. So thank you very much. My name is Craig Seymour. I'm a GP and I'm the clinical director of the North One Primary Care Network, which is in Islington, which is in North London. Just to orientate you, because I know that people will be from all over the country. So that's Greater London, and Islington is there. It's one of the smallest boroughs in London, being a couple of miles wide and a couple of miles tall. It's got a population of about 250,000. And then North Islington, which is my patch, is around about 100,000 of those. But Islington is certainly was until recently the 5th most deprived borough in London, and consequently in the top 10 of deprivation within the country. And then I suppose with the IFA, this is the heat map of Islington's social deprivation. The darker the green, the more deprived. And so I suppose my patch with a horizontal sort of slightly diagonal line that halves the borough, you'll see that the darker green is often in the top of the borough, also a bit towards the east as well. So we, as a bit of background, we wanted to do something that was going to support that population. And so we know that lots of people, particularly actually, we're very lucky in Islington, probably more so than lots of other places around the country, in the sense that we've got loads of services, but actually those services are really poorly coordinated. They often, people have got multiple needs, but will often end up with loads of different referrals. People will turn up to any open door, as they rightly should, particularly in general practice, and GPs just don't really know how best to help them because there's too many things out there and no one can possibly know all of them, and they're not very well coordinated, and the information has really struggles to flow, particularly if people are asked to have supporting information around housing or supporting medical information. Actually can just be a right old mess for both the professional and of course the person who is on the receiving end who's often in a very vulnerable position. So we, through the primary care network funding, we had social prescribing link workers, which is what the SPLW bit there stands for. And that connects directly to the GP practice and the groups of GP practices. It has access, they have access to the clinical record through EMIS as being an extension of the practice team. And then they liaise with different bits of the service. IMAX, for example, here is the income maximisation service, which is to do with the council around benefits and also housing, the voluntary community sector, Age UK, which is one of our local social navigator and community organisations. Hang on. There we go. So more specifically within our patch, we work with 2 voluntary community sector organisations, Help on Your Doorstep, who is an organisation which is quite sort of specialist in terms of working with people with deprivation type issues, housing, benefits. They've got great links with the Citizens Advice Bureau, with the Law Centre. So we employ 2 social prescribers through them. And Manor Gardens, who is a community organisation, been around for more than 150 years now, who also works particularly with multilingual communities, people, refugees, and such like that. So we actually have a job share, 1 whole-time equivalent link worker. And that's been part of an extension of our link worker system, totally linking in with this idea that you can't have a link worker in isolation. We work with these organizations because they already have connections, they already have infrastructure, which is so important not only for the individual but also to maximize efficiency. And we haven't seen turnover, touch wood, of social prescribing link workers, which I know other PCNs have, particularly if they're working in isolation, which just sounds really lonely. But we also have maximised our offer here as well by working with the Camden Islington Mental Health Trust, which is CNI there. And we have health and wellbeing peer coaches who are basically there to support people to kind of, I suppose, people who kind of, we try and describe it as people who kind of got stuck, often through chaos of life and situation, to support people to be able to set goals and to be able to engage with the system. And the link workers and the peer coaches are building a network of a system in order to try and support people with really complex needs to be able to move forwards. So we're trying to build something that feels a bit more like this, actually, rather than a link worker having to reach out 10 times to 10 different organizations, but rather to build a kind of an organization which holds hands and is emotionally co-located with professional links, so that actually we are behaving in the way that our clients, patients would want to. The COVID response, I echo, I think it was Tim earlier, just in awe of the voluntary community sector. It was a time when I just really just watched with him. I was so impressed, particularly our local organisation, Manor Gardens, who really took leadership around the COVID response, specifically around identifying people who are in food poverty, who just didn't have access, just couldn't get out and didn't have access to food. They were so quick off the mark. I was so impressed. But I suppose what we've discovered is that discovering people in food poverty wasn't just about COVID. It was also, we were just unmasking people who had poverty. And they weren't issues that once the original lockdown eased, it wasn't that they couldn't get to the shops. It was that they were often multi-generational families living in inappropriate accommodation below the poverty line. And so actually the organisation was still delivering food parcels well into September, almost just as the second wave was starting, actually. But our link workers were particularly important around people who would present to general practice, and we had people who were proactively contacting those in the community to see if they needed support, if we knew that they were vulnerable, and referring to food banks and other sources of local support. But then there's also been a whole system since then, a whole system reorganisation around social prescribing. So, I mean, we've been lucky in the sense that social prescribing has been part of our infrastructure and part of our landscape for getting on for a decade. But actually, there's now a look as to whether we can create single points of access, whether we can start pooling resources which currently sit in quite isolated patches, and pull it together into a single point of access, which is a noble thing, but also comes with its own challenges. And so out of the COVID response, things like something called We Are Islington, which was then a single telephone number that people could call if they had care needs, or they needed someone to go and pick something up from the pharmacy for them, or basically, in theory, you could call with anything that was kind of social related. And that was in hand with the council. And so we're really building on those original relationships, which previously were there, but didn't really have something to do. And this really just sort of galvanized everything. And this is my last slide, just around challenges. And I'm sure if I could see you, there'd be some nods around lots of these things. I mean, we're really just seeing that there is insufficient capacity in the system. And I was reflecting a little bit earlier on that I wonder if there is ever enough capacity in the system. But actually, we just have got increasing demand. And I don't think that's COVID related. I don't think we're going back on that. And also, I know in the chat, people talking about how do we get people to know about these services? Actually, I think once people start to know about them, they start to know about them and they grow. And so we need to manage that. But it's not only about numbers, it's also about complexity. I mean, people are complex anyway, and often the people who are more complex are people who don't access services very in a way that our services allow people to. But actually, COVID has just increased complexity around housing, tenancy, joblessness, mental health, all these physical health. And so actually our social prescribers are feeling the strain of that. And also we need to be mindful about how we make sure they've not only got the right skills themselves, but they're also connected to the right people in the right way so that they're not wasting time with bureaucracy. But there's also around operational demands. These are small organizations with small numbers of people, small operational teams, and we're asking a lot of them. I'm very conscious as a clinical director that as a system, we ask a lot, and we don't want these organizations to fall over. And it's fragile, but they're amazing, but it's fragile. And then the whole system reorganizations don't help, although actually there is money in the system and trying to bring that money together makes sense. And we're moving into integrated care systems, which will be a whole new world for all of us. And beyond the, just learning the terms, actually, we still don't know what the legislation looks like. But no, the vision is around bringing social prescribing, wider determinants of health into a single arena. That's not going to be easy, particularly some of these organizations are already maxed out. And I speak as a GP, we're maxed out as well anyway. So that's me. I will come off screen sharing so that we can go back if I know how to do it. Sorry, there we go.
Thank you very much, Greg. That was really interesting. I don't think I've seen any specific questions for you at this stage, but we can kind of go back to that in a second. I think now is time for a little bit of discussion about managing caseload. So that's quite a bit of a tricky question, I suppose. But I think it would be good to share any tips, any things that, you know, all of the speakers and maybe attendees, please feel free to share some tips as well. I'm going to share as well the word cloud with everybody's tips there. But why don't we start by, there was one question in the registration form that was asking how to support social prescribing projects best going forward in light of increased demand and complex needs of clients. Does anyone want to get started on this? Yeah, Tim, go on.
Yeah. Oh, okay.
Oh, either of you.
Well, just very quickly, I think if you haven't got a relationship with your local commissioners, you need to find out who's leading for the system, either the ICS or the CCG, on making sure this stuff really lands. And I think the population health management agenda is your best friend here, because ICS is going to have to start really understanding what that means. That means understanding communities and talking to them locally.
Yeah, go on, Marianne.
And I was just going to say what Tim said. It's so important to have sort of a relationship with the commissioners as well.
Yeah, Greg.
I was going to say that I suppose one thing that I think it's absolutely right about the commissioners, although they're only one piece of the puzzle. There's lots of people who are involved in social prescribing across the entire system, particularly primary care networks, actually, and they are emerging. Some of them are really struggling. So just in case that's jargon to anybody, a primary care network is part of NHS England reorganisation. So it's groups of GP practice coming together at a size of roughly 30 to 50,000, although mine was at one point much bigger than that, and there were others like that, which are also about trying to wrap around the population. And they have a budget, an available budget to spend on workforce, which includes social prescribing link workers. Now that budget, compared with the wider budget, is tiny, and we're talking sort of small, very small numbers. But there are other opportunities to start wrapping around and building together. And I suppose as integrated care systems emerge, but also as we also wrap around populations anyway, as people look at localities or neighbourhoods, whatever we call it, is that there will be other people who are really interested in this, who may be able to pull levers or be able to make things happen. So I suppose just be mindful there might be other people in the system apart from the commissioners.
Thanks, Greg. Does anyone from Broadway by Bow want to give any tips? Maybe one of the frontline workers. Feel free to come off mute. Leila, I think you want to speak. Yes, go on. I think you're off mute now.
Sorry, could you repeat the question, please, Berenice? Because I couldn't hear.
Yeah, that's all right. No, I was just kind of wondering how to best support social prescribing services in light of increasing demand and the complexity of cases as well. So
yeah, and our link workers are here as well, so they can chip in. But just some reflections that I had was, we had a huge amount of referrals that came in during the period, like everybody else. I guess there's something around the whether the referrals are always appropriate, so whether they're always best suited for a social prescribing link worker. And what I mean by that is that sometimes you can have patients that come to their practice that simply want to be referred to, say, a social welfare service or Citizens Advice Bureau or housing support or job support, and it's a very clear need that they have. I think in situations like that, I mean, it's great that they can get connected with a link worker, but this is an opportunity here for practice staff to kind of support in that area as well, and have sort of key information when it comes to kind of local services. That would enable the social prescribers, as we said, to concentrate on more longer term support. What we've found in our service is actually, and I think somebody put it down in the work cloud, there's something around managing the relationship between the social prescriber and the client. And what I mean by that is that sometimes it's very hard to end those relationships and end that support. And what happens is our link workers end up holding a heavier caseload because of sort of, I guess, issues around or challenges around setting boundaries, and sort of being very clear about what it is that we can provide in terms of a service. I think what really helps is sometimes working within a structure. So knowing how many sessions you're able to offer somebody and being very clear about that at the beginning during the contracting stage. I find, and I think some of our link workers can talk about it, find that quite helpful when it comes to kind of navigating that relationship. Because, you know, we are, and I think Craig said it as well, we're dealing with some really complex issues here. And whilst when we're on that journey of building a relationship, people are kind of being very open and honest about what's going on for them. And it's very easy to kind of get attached and want to hold on. But ultimately, I think what we want to see happening in social prescribing is making the client the kind of the driver of the seat of what's happening in their life. And ultimately what we want is, we don't want that person to come back to us, because we want to see them kind of, if they're put into a similar situation, being able to navigate that on their own and being able to connect to local services themselves. I don't know, Alex, if you want to chip in or anything, or Naseem.
Yeah, I mean, what I will say is, I think I have learned, sorry, I can't seem to start my video though. From experience, actually. I think experience is as unhelpful as this may sound, experience is probably the best way of learning why boundaries are so important. I remember agreeing to see someone on a bank holiday because I really just wanted to help that person. They were in a very difficult situation, but actually what ended up happening was a safeguarding incident, and I couldn't report to the surgery because it was a bank holiday. And so that took up about an hour or two of my bank holiday that I shouldn't have done. And that, I think, after the end of that, and luckily it was sorted, but at the end of it, I sat to myself and I thought, this is not worth it. Either I keep pushing myself to these boundaries, through these boundaries, and burn out, or I respect there is a reason why there should be boundaries. And I think that for some people, it is a bit of a learning curve in terms of how can we stop pushing ourselves. I know, I agree. I think I just read somewhere, someone saying the difference between kind of how do we make our caseload manageable rather than just having numbers. And I think that is a difficulty, particularly working within the healthcare. Some people just want you to continuously see patients, but when you have that, it's more about getting through the cases as opposed to actually having meaningful engagements. And there is, unfortunately, I don't have an answer for that. But yeah, it is a case of learning your own boundaries, sometimes from experience, hopefully not. But for me, I know that I had to have experience to really understand why we had to put structures in place. I don't know if that makes sense. Hopefully it does.
Thank you, Alex. Naseem, I see you've...
Yeah, so I think having structure is so important, because when I first started, I really found it difficult with boundaries. Just sort of, if somebody was without food, I would just go and deliver it to them, regardless of what time it was. And over time, I've realized that that's not something I should be doing, because it's having an effect on me as well. And like Alex said, I think we've all done it when we've called people either sort of late in the evening, or even during, like she said, over bank holidays, just because we can, because we're so worried about that person. But it's just learning to put, and I think like to have those boundaries is just through experience, as Alex said. I think it's just something you learn. For me, I'm the same as Alex, that you need to, so I learn through experience, and that's how I put my boundaries, even though I know that I shouldn't be doing this, but you just want to do it because you think it's going to help that person. Yeah.
Yes. Thank you, Naseem. Tim, I see you've raised your hand.
Yeah, thanks. Absolutely agree with everything that's being said. I think the role of supervision is absolutely crucial. As someone who has supervised managers of link workers, it's that ability to say, why are you still holding this case? understand why, but focus obviously on what's achievable and can be achieved, and when it stops being achievable, because sometimes you can even feed into people's kind of psychological games trying to help them when they don't want to be helped, and all sorts of other complexities. So that supervision is absolutely critical. I see one of the chat colleague in Suffolk's mentioning the importance of difficult case chats, and certainly if you've got a team, then having those conversations, I think that's already been mentioned, really important way of helping people think this stuff through. But I come back to also the focus on what we think we're trying to achieve, because there's always going to be more to do than you can do, and you need to be with the clinical directors, with, if you're hosted by a voluntary organisation, with that organisation being really clear what we're trying to achieve this year, and what's a reasonable amount of work to be able to do. And we're lucky that we've got a system that allows us to record how much time each case is taken, and that also allows us to analyse, you know, where the efforts are going. And I think in terms of addressing health inequalities, that will become increasingly important. And I'm answering because I think Marianne's had to leave, who would probably give a much more sensible answer.
Thank you. Yes, Marianne had to go get her vaccine, so this is a very good excuse. There was also a question about what does a good caseload look like, and what kind of numbers are we looking at in terms of everybody's experience. So I don't know who wants to get started on this. It's also a difficult question, but. Craig, you haven't spoken in a bit, so maybe you want to start with this?
Yeah, I think I'm probably the least well qualified to answer that question, unfortunately. I know that, we had this conversation because we were reviewing our service. I think there was something, it was something like 30 active cases at any one time. Like it was something in that region. I probably hopelessly misquoted. But I think what I do know is that number, there isn't an absolute number, and it really depends on the complexity of the cases that you're managing, and also from what it sounds like, the ability to hand bits off. So I'm really conscious that our caseworkers are getting a lot of referrals about housing, which, I mean, actually in a borough like Islington, and I don't know what it's like where you are, but there isn't any housing. You sit on a waiting list for years and there's no housing. And if you're a single, relatively well young man, then forget it. And so actually, if you are in housing, even if it's hopelessly, not the right kind of housing, then the chance of being able to shift up and down is quite there. And actually, our social worker is getting referred a lot of people through from the GPs because, this person needs help with housing. And that's okay, actually. That's kind of what we told the GPs, that's what they can do. But then they're getting held in the social prescribing link worker system because actually there's nowhere for that to go. I mean, what we're trying to do is recognizing that is we've got some really good relationships with some of our colleagues in housing who are then, we're testing having sort of a specific forum where link workers and other people in the system can bring specifically housing cases, and also trying to clarify, particularly because there's a lot of noise in the system around people wanting letters and things like that, is then trying to clarify actually, well, what information do people need? And rather than people bouncing around or going to the GP or going to whoever for information, is how do we then reduce the noise? Because actually, although it is all about helping our clients, patients, residents, of course it is, you also have to make sure that the people working within that system aren't about to fall over. And I look around me at the moment, and I just, not here specifically, you guys all look great, but I worry specifically about, in my area, I just look at people and think, ooh, everyone's knackered. And we don't quite know what the next 6 months are going to bring, and we need to try and make sure that the people who are working within there are going to stay, so that we don't all just collapse in a heap, because that's no one any good.
Thank you, Craig. Leila, do you want to maybe chip in as well in terms of what a good number of clients at cases at any one time looks like? I'm not sure if you're here with us now, as you're off camera. Yes.
Really have issues today. I'm really sorry.
All right.
We have roughly around, I would say on average, on a monthly basis, we will see around 50, we will get around 50 referrals. Of those referrals that we get, a portion of those referrals directly go to our BBBC in-house services, such as the social welfare services, the employment and skill services, sports and physical activity. So in that respect, we're really fortunate that we're able to kind of hand over a portion of our referrals directly to those services, because there's a clear need. There isn't a need to see a social prescriber necessarily, but there's a clear need for, say, social welfare support. We, on average, we say on a daily basis, so if we have a full-time link worker, we say that 3 days out of the week, we should be seeing clients, we should have a caseload of clients that we're seeing. We see a maximum of about 3 to 4 patients in the day. Our sessions last around 50 minutes. So they're quite sort of in-depth. During that period, the link worker is able to kind of action plan and have a sort of open conversation. And if signpost needs to happen, then that happens then. I know that Craig mentioned sort of social welfare and housing support. This is a huge thing with our link workers. We find that in most cases, every referral that we receive will have an element of a social welfare need, whether that's housing support, benefits advice, financial management advice, etc. What we have done recently is actually team up with our social welfare advisors. What we understand is, and I know that probably other link workers on the call are going to feel this, there's a real anxiety sometimes around dealing with social welfare issues, because a lot of the time you do need a trained person to be able to give advice. Otherwise, things can go really wrong, and we don't want that to happen. So what we've done is teamed up with our social welfare team, and they've offered us, our link workers, a drop-in session where link workers can come on a weekly basis and talk about any social welfare related issues that are presenting with their client. It's also a time for the sort of qualified social welfare advisor to give that link worker advice, and where possible, be able to say when there is an activity that can be done by a link worker, because there are some social welfare issues that can be done by a link worker that can just free up time, such as if you want to complete a disability badge for somebody or a warm home discount. Those kinds of things can be done. So we've found that really useful. But yeah, I think I might have answered. Again, Alex and Naseem, please chip in if I've said anything wrong.
Thanks, Layla. I actually have one last question about managing caseload. Another tricky one, I suppose. What do you do about the cases you cannot move forward? So feel free to chip in, anyone. I see Tim smiling. Go on.
Oh, obviously, it depends on why you can't move it forward, I think. I mean, one of the reasons we originally commissioned the service long before NHS even got involved was to find out as commissioners what was missing, because we thought that link workers would actually flag that stuff up. Actually, a lot of the time we found A, that there was stuff out there, but people just didn't know about it, but they found it, and B, that they found solutions by getting different people to work together in a way they hadn't before, which meant we didn't need to commission anything specific. But obviously, sometimes, I mean, hoarding services is one of the big ones for us. And that's partly also because our community navigators visit people at home. And when you visit people at home, you find out stuff the GP never sees and social worker often doesn't see. And hoarding is one of those things. So we know that's really problematic to get that service, but we're trying to develop that. And there's a lot of issues around how you support people who are waiting for services, and that's going to be increasingly important now. People are waiting for operations as well, actually. That I think there's a lot we can do with social prescribers to help those people be plugged into support so they don't go downhill quicker than they need to. So I mean, I think it depends very much, and as I said earlier, there are some people who are actively, for deep psychological reasons, trying to not be helped and you have to be able to draw the line. And again, it's where it's really important that supervision is skilled and available to people. Does that answer it at all?
I think that makes sense, Tim. Emma, you've just appeared. Do you want to add to this?
It's quite weird, isn't it, when you just sort of appear on the screen? Yeah, I was just going to say as well, I suppose this is one of the things that we've been exploring and has kind of really come to the fore during the pandemic. So the kind of community-based help, which has nothing to do with a service whatsoever. And I think that tapping into that, you know, once you've concluded a lot of the things that Tim is speaking about, it's kind of breaking that reliance on a service and giving people kind of opportunities and space and I guess time to explore other sorts of things that they might get involved with. So I think part of the really exciting thing of having Communities Driving Change as part of this wider team is that they support exactly the same clients but in a completely different way. So actually their approach, and Jess and the team will be able to speak more to this, but their approach is much more around kind of what's your skills, what's your interest, what can you do in the community, and kind of creating opportunities for people to kind of build on those sorts of things. So the intervention actually isn't with a social prescriber, but the intervention is about, okay, here's £500, what can we do with that, and what change can you make in your community, or where are the neighbours that are around you that are, you know, facing similar challenges that we can connect you to. So I think it's also about kind of, sometimes we think that in services we're the only people that can sort of help the person, but actually what we've learned through the pandemic is the power is really in the community, and kind of weaving people back into that as well, I think is another option for clients that come through this sort of pathway.
Thank you, Emma. Does anyone want to add to this question, or shall we move on? All right, we've got one last kind of theme for discussion for the last bit of the webinar, and that's about what are the lessons learned and what do we think the future of social prescribing looks like. So that's another interesting topic. And I think I've got some questions that can fit in this category on Slido. So first question is, do you think the targets proposed in the IIF poses as a risk to social prescribing? Do you think it might change social prescribing offer as we know it? Yes, Steve.
Sorry, I think I have my hand up anyway, which is appalling.
Yeah, exactly.
I do apologise. Yeah, so I think the IIF is to be treated with extreme caution. And I come back to the point I made at the beginning. Why are we doing this stuff? It's not so we can say we did 430 of something without knowing what that means. It is about addressing real health inequalities in our communities. And, you know, we have to think about how we do that most appropriately. And for me, and you know, some people would think I'm a social prescribing purist, but actually I think if 50% of the social prescribing link workers' time is spent on something other than social prescribing, that's not the end of the world at all. If it's productive, if it's, you know, community development, if it's outreach to people who haven't been referred, but that, you know, 10% of those people then have a much better outcome than they would if they'd just been left to fall apart quietly, then that's a win. And nobody should be embarrassed of focusing on that work just because the IIF target would encourage them to do something different. And I think if you go back to the fundamental principles of social prescribing, it's about giving people time. And if we start saying you have to do, you know, stack them high and sell them quick sort of thing, then that's not social prescribing anymore, it's something else. And we have to really, really stand up for quality social prescribing that changes people's lives, not tokenistic tick boxes.
Thank you, Tim. Does anyone else want to add to this question, to this response, I guess?
Yeah, I'm gonna agree with Tim. I think we do have to be really careful with. I mean, we're seeing the rising, the referrals certainly locally to social prescribing were there without people even knowing what the IIF was, of which still most people don't. So don't worry if you didn't know what it was to anyone. But actually, it's that people are referring because there's a need there, and then I suppose the onus is then on the local system, because the needs of sort of my inner city population actually may not be that different from the needs of your rural population, for example, or there might be a lot of synergies, but actually the way you might go about meeting those might be quite different. And so I suppose it is down to those of us who work within the system to recognise that and not look at it in a basic way of we have to meet the numbers. I mean, by the way, also the amount of money attached to this is tiny, so that's not going to be a driver for anyone, or it shouldn't be. The reality is actually, well, how do we look at this need that's coming through, and then what are the links? And locally, we know there's a lot of links with mental health, and particularly low-level mental health, so non-enduring psychotic level mental health, which is what the system often focuses on or has commissions around. But actually, it's the things particularly that are very common in the population that seem strong in general practice that are all such as depression, anxiety, agoraphobia, which also are really, they're the same people that are struggling to access services in housing and in the voluntary community sector, and in and families around schools. And it's often the similar populations who struggle in lots of different ways. And how can we look at this as a system that goes beyond health, because only direct health is only sort of 20% of those determinant factors, and think about how we can then utilize some of the opportunities that we have. And I often refer to it as sort of lemons. Actually, maybe what we want is orange juice, but we have lemons, so what can we do with it? What my colleagues want, they want doctors and nurses as part of the PCNs, well, you can't have those. But what we do have are social prescribers, peer coaches, case workers. How can we do something interesting with this? And I think that we can, but there's a real onus on the system to think about things differently, rather than just in terms of tick boxes and money and numbers and targets.
Thank you, Craig. Shall we move on to there's a question, and I think that's pretty much the theme of this anyway. What do you think have been the positive changes, and how will you use these to influence and shape your service? I don't know, maybe Bromley by Bow, someone from Bromley by Bow wants to respond to this in terms of what have been the good things in the last year and a half. No one is on the screen now.
I was going to say, I'll let somebody else speak because I feel like talking all day.
Jess or Emma, do you want to chip in now?
I'll just say a bit then. I think the positive things have been that as a more kind of community engagement, community development project, we've been able to be have a different level of responsiveness to community, and as covered earlier, we were able to interact with and reach out and provide services to people who weren't already interacting and contacting the Bromley by Bow Centre, and indeed the health partnership. So I think one of the things that really we need to continue, and what we've learned during the pandemic, is how many people could do with support around health, particularly the kind of social model of health, that aren't aware of what's going on.
Thanks, Jess. Does anyone want to add to this? Maybe Tim, do you have something from your side?
Sorry, I was just in the chat. Remind me what the question was. I was going to say something, then I answered the question.
That's all right. So what has changed during the pandemic in the service, and a positive change that will, how will you use it to kind of shape the service going forward?
I think the most important positive is that, and I get different feelings from talking to different people across the country, but in Hertfordshire, certainly the barriers came down between a lot of services, and that meant that the link workers were really well placed to navigate even more than they were before. There was a willingness on the part of the voluntary sector to work much more closely together, but also with the statutory sector. So I think that was incredibly important. The other thing for us was that as the local authority got some of the emergency monies, because the Herts social prescribing system is a thing, they were able to chuck money at that thing, and that thing was then able to support with discharges in a more rapid way and various other things, which we couldn't have done if there were just 30 separate workers all facing a different direction. So I think that was really positive. And I think across the country, there's this sense that we mustn't let that all unravel quietly as we go into the horrible post-COVID sort of depression that it may hit us. And I think we've got to keep that community action going, really.
Thank you. Craig, anything from your perspective?
I think for me, it was the real rise of the voluntary community sector as community leaders. I think prior to that, I always heard the voluntary community sector sort of referred to as being, you know, they were the end of the slide. You're going to go, and also you can refer to the voluntary community sector will do that, or you can pass them on. And actually, I've seen the voluntary community sector, certainly locally, move to the centre, really the core. And I think certainly the diagram, I hope, is being redrawn now, which it used to, you know, particularly in the health sector, which was, you know, hospitals, general practice, community. And actually, I think that there's a real importance of the voluntary community sector to support people to remain in the community, but also to work as a real core part of keeping people well and connected and the wider determinants of health. And I'm really seeing them less as part of sort of people who you might engage with, but actually far more as I go to them as clinical director saying, what do you think we should do about this? Or we've got this opportunity, what do you think we should do? And that's exactly where they should be. They're far more connected to communities in a way that I haven't seen, even more so than GPs and general practice is, although they are more connected often than hospitals. But actually, they're really ingrained with councils and with the community and with community leaders. And so I think that I'm hoping to see more and more and more of that.
Thank you, Craig. There's a question about how to establish a team of social prescribing link workers within the PCN after the lockdowns, seeing patients again and community interactions. How can we deal with those challenges in terms of establishing a team of link workers? Does anyone want to chip in here?
So, sorry, I can't see if I'm butting in. I think the key thing is, as Alex mentioned, is the link workers reaching out to other link workers, but commissioners taking responsibility for trying to see that there is proper infrastructure for social prescribing. Because if they're single workers employed in one PCN, then they are going to be isolated unless they're plugged into something more strategic at a locality basis. And obviously that depends on where you are. We have district councils as well as the county council, but you know, London's different, blah, blah, blah. But I think it's understanding that just as the sector worked brilliantly together during the crisis, and link workers have tried to where that's possible, but that you'll get more value from the same investment if it's all properly connected.
Thanks. Anything to add to this? Or I have one kind of last question. Right, so one last question is, how do we see the future role of link workers in the personalized care agenda? So another tricky question.
Yeah, I think I mean, absolutely yes. You know, if there was a one-word answer, it'd be yes, they do. It wasn't a yes/no question, but that's my way of getting out of it. I suppose one of the things that we're struggling with locally, and I think we've got quite a switched on system locally, is how do you try and bring what is actually a very broad thing, social prescribing being a jargon and also a very, very broad concept, into something which then you can then try and make the most of budgets and people and then connect it. And people struggle with that with general practice because they're, you know, we're multiple different small things, all of which different ideas. And so actually quite hard to engage with us. And actually there's still something around how does a system try and bring everything together? And so I think we do, some of it will be pulled together. So the primary care networks are going to have a personalized care contract, which will help to pull some of this together. Locally, and certainly our CCG and our local mental and community health systems are trying to pull together. They recognise the value of social prescribing, of people who are there to support people in a wraparound way and looking at population health. I think as we move into integrated care systems, there's going to be a real challenge around how do voluntary community sector, some of which are various different levels of voice and standing and size, are able to have a voice and to participate within that. And I think that's going to be a massive challenge for all of us, actually. So yes, there is a massive role for personalised care, within personalised care, but then there's a whole load of set of, well, what does that mean? Which bits of personalised care are people looking at? And in what way can we try and pull together so we're not doing disparate things, which then actually just dilute the pot?
Thanks, Greg. Emma, do you want to add into that?
Yeah, just briefly, I think I think what the pandemic has really shown us, if we didn't already know it before, is at least 70% of people's health and well-being is made up of kind of other stuff that isn't to do with, you know, physical health and sort of medical care. So I think in as many places where we're talking about care as possible, this agenda of kind of wider determinants and social prescribing needs to be featured. And I think also we need to get away from, I think Layla mentioned it earlier, that every single thing to do with your wider well-being needs to be channeled through a social prescriber, because it will just break every single person that is called a social prescriber. And I think it's not fair when we know that so much of people's health is driven by these things. So I think that's one thing. I think the other thing is really thinking about whose responsibility it is to change. So often the narrative is, you know, social prescribers need to get around the table, the voluntary sector need to get around the table, but equally the people who, you know, own the table need to make space for that. And so as and when people who are, you know, whether they're working in a care coordination capacity or a social prescribing capacity, need to be able to join that conversation, not as a last resort, but as people with a high level of expertise that can contribute to that person, to that individual and that family's care, so that when so that it doesn't create referrals and sort of bottlenecks, but actually it's just a way of managing that person, rather than it being, okay, now you're going to go to that person, then you're going to go to that person, and then that person for each element of care. What we're working on at the moment as well in our sort of general practice is making sure that wider determinants feature in all long-term care, all long-term condition reviews. So whether it be diabetes or COPD or asthma, but actually, as we know that many of these things are driven by, like I say, like the wider determinants, that actually they're factored in at just many more spaces. And I think it's about, yeah, dispersing the conversation rather than channeling it all towards social prescribers. But yeah, I agree with also a lot of what Craig was saying too.
Thank you, Emma. Great, we're actually just coming to the end of this session, so right on time. Thank you so much all for staying with us until the end, and thank you to all the speakers to share their experience. I've also put a feedback poll up for just a little bit of a like 30 seconds kind of feedback for us to know how you found this session. Like I said, this was recorded, so you will receive the recording as well as slides and any links that was shared. All of this is kind of like gathered together, and you will receive this probably in the course of next week. So yeah, thank you very much, everyone, and I hope this was helpful and interesting to all of us. Thank you, everyone.
Thanks very much, everybody.